All right, we're going to go ahead and get started. Thanks again for joining us today. My name is Samantha Gomberg, and I'm PTPN's Account Services Representative, and I'll be your host. Today's event features one of our preferred vendors, Graston Technique, and during this webinar, Jackie Shakar, DPT, MS, OCS, LAT, LMT, and Graston Technique Clinical Advisor will offer a better understanding of soft tissue injury, healing, and potential reactivity to instrument-assisted soft tissue mobilization, therapeutic and adverse. And her subject matter will include history, physiological rationale of ISM principles relating to soft tissue dysfunction, and anticipated results. Jackie will also highlight the latest applications and research supporting the Graston technique as her go-to intervention for restoring mobility restrictions. I'm very pleased to introduce our presenter today, Jacqueline J. Shakar. Jackie is the clinical advisor for the Graston technique. She completed a transitional doctoral degree at Massachusetts General Hospital Institute of Health Professions in 2010. Jackie became a board certified as a clinical specialist in orthopedic physical therapy by the American Board of Physical Therapy Specialties in June 2011. She earned her master's degree in physical therapy from Boston University in 1983. She's been an athletic trainer since 1984. She received a certificate in massage therapy from the Bancroft School of Massage Therapy in 2001. Jackie has maintained a clinical practice in musculoskeletal physical therapy for more than 27 years, specializing in manual therapy and lower extremity biomechanics, including custom foot orthotics. She's a full-time professor at Mount Wachusett Community College, where she has taught anatomy, kinesiology, clinical orthopedics, and evidence-based practice clinical research for more than 20 years. Jackie's an avid runner and works with a number of elite and recreational runners and triathletes. She also works with high school and college athletes. She's been a Graston Technique instructor since 2007, and as you know, Graston Technique is one of our PTPM preferred vendors, and members get a special discount on training and instruments, so you can contact them for more information. And with that, I'm going to turn it over to Jackie.
All right. Well, thank you very much. I'm actually quite pleased to be with your organization and sharing what I know in this brief but hopefully informative session about instrument-assist soft tissue mobilization, specifically the Graston technique. The Graston technique is the system of instrumentation that I use in my clinical practice. And Sam, thanks for going through my history and whatnot. As you said, I've been a physical therapist for well over 30 years in clinical practice, and the Graston technique has been one of my, if not the go-to intervention when I'm trying to work on soft tissue and joint restrictions that might be due to a soft tissue issue. So I hope to share a little bit about the technique, my clinical practice, and then at the end go through a case study so that you guys can really see how I do things. So here are the objectives for today's webinar. I want to introduce those of you that are new to the concept of instrument-assist soft tissue mobilization, a little bit about the physiology. Physiology of instrument-assist soft tissue mobilization is essentially the same as it is for manual techniques, but I'll present some of our findings to show why it may in fact augment, make your treatments that much more efficient. We do have a considerable amount of research. We have more and more that's being done every day. I added a study to this presentation since I put it together several weeks ago. And then, like I said, I'd like to present a case study just to kind of illustrate how I use GT in my clinical practice. The Graston technique is a federally registered trademark. We feel very strongly that only clinics that have been trained by one of our certified instructors and use our instruments can represent themselves as using the Graston technique in their clinical practice. And I'll talk a little bit more about that shortly. We do require mandatory education. So we have 2 levels of training. Our M1 is a basic training, which is a 12-hour course. Basically, we introduce you to the Graston technique instruments, applications regionally, the extremities and spine, And then beyond our M1 basic training, we do have an advanced training. It's a 14-hour, very clinically applicable course where we go further into clinical applications using the Graston technique during movement, load and weight bearing, integrating therapeutic exercise, and at times provocation in a 3D movement type system. So first part of this webinar, what I hope to do is just introduce the participant to the concept of instrument assist soft tissue mobilization. Those of us that perform a lot of manual therapy in our practices, we're used to using our hands. And I found when I first started using the Graston technique instruments that I could augment the effects of my manual treatments quite effectively. There are a number of different materials and instrument types out on the market. This next slide shows some of the different systems. Probably the oldest system of instrument assist are the gua sha instruments, which are shown on the picture on this slide. The Graston technique is one of the oldest systems itself. We've been offering training since the latter part of the 1980s, 1990s, and we've just seen a tremendous growth in the interest and participation in our seminars. And I hope to present a little bit more evidence as to why that is so. So if you're a manual therapist, you might feel like you're very effective when you're using your hands, your manual skills. I found in my clinical practice that after about 15 years of doing primarily manual therapy, I was developing some soft tissue and joint issues in my own extremities. And so I initially considered the Graston technique to try and relieve some of that pressure and stress, so there was an ergonomic motivation for my reason. What I found pleasantly as I started to use the Graston technique instruments in my practice is it's actually increased the sensitivity of my hands. So in other words, I haven't stopped using my hands. I use the stainless steel Graston technique instruments to augment what my hands were doing alone. And over the next couple of slides, I will introduce the participant to some of the stainless steel properties that enable your hands to become that much more sensitive, that being mechanotransduction, fibroblastic proliferation, and the concept of piezoelectricity. So as I mentioned a couple slides ago, there are a number of other systems of instrument assist soft tissue mobilization. Quite honestly, I started first using a reflex hammer handle, found that it was somewhat helpful. I then moved on to gua sha instruments, and then fortunately very early on in my journey found the Graston technique instruments. I attended a training, and I've been using them in my clinical practice ever since, and that is more than 14 years. We would argue that our instruments are superior to some of the other systems, mainly because of the design and weight. That's difficult for me to relay in a webinar. If you work in a clinic that has Graston technique instruments, I would encourage you to put them in your hands and just feel the material, the density. And then more importantly, I would argue that our delivery method, our mandatory education, puts us head and shoulder above our competitors. The Graston technique is not just about taking a dense stainless steel object and rubbing it back and forth over the skin. We've designed over 13 techniques, strokes, if you want to call them that, to really augment many of the manual techniques that most of us were doing with our hands alone before we started using the Graston technique. So just to define GT, as we sometimes refer to it, incorporating the use of the 6 stainless steel instruments to help you, the clinician, detect and treat soft tissue dysfunction. Furthermore, we would consider it to be an advanced method of instrument-assist soft tissue mobilization, but it's not just the instruments alone. It's the Graston technique instruments, the strokes that we've developed, but important to combine it with the rehabilitative exercises that help improve musculoskeletal function. So I want to pause for a second on this slide. The Graston technique is our instruments, our strokes, our techniques, but used in combination with appropriate rehabilitative exercises in an effort to remodel and realign the soft tissues that might be causing the musculoskeletal dysfunction. This slide here basically gives an overview of a typical treatment. So, and I would argue that the Graston technique treatment that you see on the slide should be preceded by a comprehensive evaluation, identify that there are no known contraindications, and that the movement dysfunction that you are assessing in your patient is due to some type of soft tissue or joint restriction. If you find that is the case, then I would encourage the inclusion of the Graston technique. And basically, we encourage some type of preparatory soft tissue warm-up. It could be manual massage. It could be using a foam roller. Some of our clinicians warm up the tissues using local modalities such as ultrasound or moist heat. And then I would argue after the soft tissue warm-up, we proceed with the actual application of the Graston technique instruments, followed by appropriate therapeutic exercise, whether it be stretching, fascial mobility exercises, strengthening. And in our M1 training, we basically teach you how to use the instruments and demonstrate some therapeutic exercise applications. In our M2 training, we actually cover the complementary rehabilitative exercises quite extensively while incorporating the Graston technique into your treatment. A little bit about the history of the instruments. David Graston, the name Graston technique is taken from his last name, was actually a professional water skier who sustained a career-ending injury, and because he benefited so much from the soft tissue treatments that were done to him in physical therapy, he tried to render soft tissue massage to himself, developed carpal tunnel because of his background in tool and die, started to play around with different instruments, and at that point combined with several clinicians, and based on the initial principles of James Syriak's cross-friction massage, the first instruments were designed. The original instruments are the instruments that we still use today. They were originally patent protected. And we promote the fact that the Graston technique has ongoing research and development that substantiates its use and just continues to evolve and add to what we already know about what we're doing with our treatments. So how do the instruments work? Well, I liken a Graston technique instrument, which we're going to take a look at the instruments in a couple minutes. I compare the Graston technique instruments essentially to a stethoscope. If you're listening to a heartbeat, a stethoscope would enhance what you were hearing with your ears. And I would argue that the Graston technique instruments do the same thing. In other words, because of their weight, their design, their density, they amplify the feel of the soft tissue restriction that you might be moving over with the instrument. So again, some people worry that using an instrument is going to take away from the sensitivity of your hands. I would argue that it, in fact, enhances and adds to what my hand feels alone, just like a stethoscope enhances what my ears might hear. these next few slides, we're going to talk about some of the proposed physiology behind the Graston technique. This study here was conducted in the actually late 1990s, and basically it was an animal clinical trial, and it compared light, moderate, and heavy pressure using the Graston technique instruments. Basically, the animals were sacrificed and the tissues are biopsied. And what you can see from the slide is that even light, but more so moderate and heavy pressure, increases fibroblastic activity. So a couple things about this slide. Initially, we thought that heavy pressure needed to be utilized in order to recreate this inflammatory response. What we found in the last 10 years is that you can get a very therapeutic effect of increased fibroblastic activity using light and moderate pressure. So the idea that instrument assist has to cause bruising or be painful is just that. It's a myth. Our over 17,000 GT clinicians experience tremendous clinical success using light to medium pressure, and we are able to facilitate the fibroblastic activity when you use the instruments in a pro-inflammatory manner to create a very positive change in the soft tissues that you're working with. Another physiological effect of the instruments is this concept of mechanotransduction, the physiological process where cells sense and respond to external mechanical loads. And this phenomenon has been studied in a number of interventions that we do, primarily manual therapy and therapeutic exercise, but it is theory. It is continuing to be the topic of ongoing research and development, but basically the mechanism behind mechanotransduction is that some type of load, in the case of the instruments, the Graston technique instruments, I would say the weight of the instrument shearing across the soft tissues stimulates cell activity, and then cells that are stimulated communicate with cells near and far in the area, and that's basically how one of the mechanisms that we use to propose the tissue repair and remodeling effect of the instruments that we see in tendon, muscle, cartilage, and bone. The next physiological effect that we hypothesize, there is some empirical evidence, is that of piezoelectricity. Piezoelectricity refers to the ability of soft tissue to generate electrical signals when subjected to mechanical stresses. So basically, and this was originally studied by the authors that are listed on this slide in 1964. They studied the electrical behavior that can be measured when soft tissues are sheared one on top of the other. So furthermore, the authors of this particular study found that there was maximum electrical signal that was produced when a stainless steel object was sheared over tissues with some type of shear and compression force. The piezoelectric effect in this study was measured at 45 degrees, and we would propose, when we teach our participants to use the instruments, we suggest a 30 to 60 degree instrument angle application. There are some exceptions, but it is based on this initial research indicating that there is the creation of some electrical activity. And piezoelectricity and mechanotransduction actually kind of work hand in hand. The cell-to-cell communication is facilitated by the generation of the electrical charge in the tissues. So that's a little bit about the physiology. When I'm teaching on M1, I ask my participants just kind of think about the effects, the pro-inflammatory, mechanotransduction, and piezoelectric as they occur as you move the instruments over the area that you're working on. The next section of the webinar, I wanted to talk briefly about some of the research. There has been ongoing research since the early 1990s, and much of the research that is being done concerning instrument-assist soft tissue mobilization, I'm proud to say, has been done by our clinicians, not company-supported, but GT-trained clinicians that study the effects of GT in their academic or clinical laboratories. In reviewing all of the research that is available, using an evidence-based practice hierarchy of evidence, I would hypothesize that the grade of evidence for support of the Graston technique follows in the C and E category of evidence. So E has to do with preponderance of animal studies. We do have a number of randomized controlled trials, but they have been done on animals. I'm going to introduce several of them in a couple of slides. And then because most of our human studies are case report, case series, that would fall into the weak evidence category. We are in the process of conducting some larger scale randomized controlled trials, which I will talk about in a couple of slides. So one of our more powerful studies was published in 2009 in the Journal of Orthopedic Sports PT. The study itself has been reproduced several times by Terry Logmani, the primary researcher on the study, but basically over a number of different investigations, she's looked at the effects of instrument assist cross-fiber massage, both on fibroblastic and vascular morphology in healing knee ligaments. So in her studies initially, that was published in 2009, she was able to show significant ligament stiffness and strength. And then in some of her subsequent studies, she also showed an angiogenic type response, and that collateral circulation was developed in the GT-treated ligaments 3 weeks after the last GT treatment was administered. So this slide is from her original study, 20 laboratory rats, surgical transection of the medial collateral ligament, 7 days after the transection. The GT-treated population received 1 minute 3 times per week, total of 9 sessions, GT strumming, which is our cross-friction, and then they compared the effects to no treatment and to manual cross-friction. Okay, so looking at these slides, far left you see a normal ligament, next slide over, an untreated, and then in the remaining slides you see the GT-treated ligaments, the tissue that was generated in the healing ligaments was stained so that you can see a much more aligned fiber arrangement. And she actually measured the ligaments on a dynamometer after sacrificing the animals and found them to be both statistically significantly stronger and stiffer. This is pictures from the same study, and again, far left, normal MCL, middle is an untreated medial collateral ligament, and then far right is a GT-treated collateral ligament, and again, you can see a much more organized and substantial fiber arrangement in the GT-treated medial collateral. We've done a number of case series and case reports. We've studied tendinosis fairly extensively, and in this particular investigation, the Graston technique led to a successful outcome in a case series involving Achilles tendinopathy. This was presented by way of poster in New Orleans at Combined Sections in 2011. I wanted to spend a couple minutes talking about some of the future research directions. This particular is a case report published in the International Journal of Sports Physical Therapy. and it was conducted at Duke University using diagnostic musculoskeletal ultrasound. And to me, that's the, pardon the pun, wave of the future, because what diagnostic ultrasound will enable us to do is to actually conduct randomized controlled trials looking at human tissue and not necessarily needing to biopsy the tissue to prove some type of a treatment effect. So in this particular case report, it was a 24-year-old competitive cyclist who had sustained recurrent quadriceps strains. He had actually been to physical therapy and had not really experienced a positive treatment response. The clinician involved administered the Graston technique, 5 sessions over a 6-week period of time. And basically, looking at this slide, you see a significant difference in the tissue, both before and then after. If you're looking at the after picture, the picture on the right, you see much more homogeneous tissue, and that was done after 5 Graston technique sessions. So you don't have to be an expert ultrasonography. You don't have to be an expert in ultrasound to appreciate the treatment effect in the tissue just looking at these pictures. These are some of the photos from that study showing the different instruments, the different sites of application that were done in that particular episode of PT for the competitive cyclist. And that study and several other pilots have led to the larger, more powerful studies that are currently being conducted at Indiana University. And basically, our GT clinicians, colleagues at Indiana University are using diagnostic ultrasound pre and post Graston technique, and they're looking at 2 very large populations, plantar fasciosis and Achilles tendinosis. And so we look forward to learning about their results sometime later this year. Again, they're conducting very large-scale studies and hopefully imaging the tissues before treatment, during treatment, and then after. And so we're very excited to eventually learn about their results. This last study actually was published recently. It became available as I was putting together these slides, and basically, again, it was Terry Logmani's study on instrument assist cross fiber massage. And basically, in this study, instead of looking at fibroblastic activity, she looked at circulation. And basically, what she found is that the Graston technique caused significant long-term angiogenesis in the GT-applied MCL injuries. So again, same design as her previous study, but instead of measuring tissue strength and stiffness, she looked at circulation, both after each session and 3 weeks after the last session. And she used Graston technique GT6. This is one of our instruments. The treatment edge is starred in order to do the treatment. And interesting, her results were very interesting. The Graston technique had no change in local circulation at 5, 10, or 20 minutes post-treatment. And that's this graph over here on the top, showing no increase in circulation immediately after the application. What she did find, which is even more, I think, significant, is angiogenesis increased in the Graston technique treated ligaments, statistically significant, but again, 3 weeks after the last session. So again, looking at the picture on the right, you see the control, red being the circulation, and then the far right shows the collateral circulation that was detected in the laboratory rats 3 weeks after the last GT session. And for those of us that treat soft tissue injuries and ligamentous injuries especially, we do appreciate that circulation does greatly enhance or inhibit tissue healing. So although this was a small size study, I think the results were very favorable and will encourage further research looking at the longer term effects of the Graston technique on circulation post-injury. So the next part of the webinar, I wanted to just talk a little bit about our instruments. Looking at this slide, you see the 6 instruments. Notice that there are different concave and concave edges. Some of them are rounded, some of them are pointed, and great part of our Module 1 training is introducing each of the instruments, their features, to the participant in terms of the different strokes and techniques that can be done. And can't tell from the slide, but each of the treatment edges either has a single or double beveled edge, and that's one of the ways that enables us to vary the intensity of a treatment session. So here they are. Again, see them a little bit bigger on this slide. There are a number of different ways to vary treatment intensity. And again, that's something that we go through in great detail if you join us for our M1 basic training. Basically, the instrument edge can be matched to the body part. So in other words, if you use a concave edge over a convex body part, that will not be as aggressive as if you use a convex edge over a convex body part. So, going back to the previous slide, if I wanted to start off with a very gentle treatment, like say to the forearm, I would use a concave edge over that convex body part. If I wanted to get a little bit deeper, a little bit more intense with my application, I would move to a convex edge, either broad, and then if I wanted to get even deeper, I might use to the, you can see the little cursor pointing to the small convex edge of our GT3 instrument. So again, there's a number of different ways to vary treatment edge intensity, and I want to just introduce you to the fact that there's a lot more to doing the Graston technique, learning it, than just looking at the instruments and moving them over a body part. So some of our concave and convex edges either have a single or a double bevel, and again, applying the instrument over the tissues with a single edge is a little bit more aggressive than with a double bevel edge. So, one of the things we pride ourselves on in our trainings is at the end of 12 hours, our courses are 11 hours in laboratory practice with very little didactic, and basically what we cover in our trainings are the different nuances of the instruments, how you address different soft tissue restrictions by body part, by diagnosis, and then how you vary the intensity of the treatment, taking into account your patient's level of acuity. So this slide here shows one instrument, our GT2, and again, there's a lot to this instrument. There's a number of different edges, angles, and part of our training process is to encourage you to become very comfortable with each aspect of every instrument as they're applied to different body parts as you go through our level 1 training. Again, can seem a little bit overwhelming when you first start learning the application, but there's a number of different factors that the clinician is encouraged to take into account when choosing different instruments to design an effective soft tissue treatment technique using the Graston technique. And these are some of those factors listed on this slide. As I mentioned earlier in the webinar, we've designed 13 different strokes to be done with our instruments. The strokes that are listed on this slide are those that are covered in our M1 training. We have 5 additional strokes as well as extensive clinical applications that we cover in our M2 training. So this slide here pictures some of the different stroke applications, and you can see that there's some of the lower slides. We incorporate movement and positioning as we do the various strokes in our M1 and M2 trainings. So the benefits to you, the clinician, are listed on this slide. And again, you have to take my word for it or talk to some of your colleagues that are already trained in the Graston technique. But increased diagnostic skills. I'm a very short individual, and I use the instruments to provide increased mechanical advantage. So again, I stated earlier that I started using the Graston technique to give my body a little bit of a rest, and I've found that the instruments enable me to work on just about any body part, any sized patient, and minimal fatigue. The other added benefit is the decreased treatment time, which we'll talk about in a second. Patients like the Graston technique because they feel what you're feeling. So as you move the stainless steel instrument over the body part, they can feel the soft tissue lesions as they get amplified, and so to me that's more empowering to them. They also appreciate the quicker improved clinical outcomes, and because we incorporate rehabilitative exercises, I find that the Graston technique really gives me a chance to focus on the rehabilitation exercises that are so important to making our patients move better. Next few slides I'm going to cover fairly quickly. These are the clinical indications. They are the same as they would be for any system of soft tissue mobilization. And looking at this list, if you are interested in research, we have empirical evidence looking at epicondylosis, supraspinatus tendinosis, Achilles. We have plantar fascial, at least case series. We obviously have our ligament studies that I talked about on the earlier slides. We have studies that have been done investigating GT post-ankle sprains. And we have some fairly compelling research looking at GT post-carpal tunnel diagnosis, pre-surgical. So again, any of these conditions that are listed on these 2 slides are the reasons why we would encourage you to at least try the Graston technique in your clinical practice. There are relative contraindications, and again, this webinar is relatively short. In our M1 and M2 training, we spend a little bit of time talking about the various indication and contraindications. So again, additional relative contraindications, and again, they are the same factors that would limit your choice of manual therapy, same for the Graston technique. And then lastly, this last slide or 2 indicates the absolute contraindications. So again, these are reasons why you would not incorporate the Graston technique into your clinical practice, nor would you institute any system of manual therapy. So one of the things that we do try to hammer home in our trainings is a treatment algorithm, and this is the M1 treatment algorithm. So following a comprehensive physical therapy evaluation, we'd encourage you to scan and identify soft tissue lesions using the Graston technique instruments. And in your clinical judgment, if you found that the soft tissue lesion that you had evaluated would be amenable to some type of manual therapy, we would then teach you how to use our instruments with our strokes. And then step 3, is to introduce and apply the appropriate therapeutic exercise. So we cover this algorithm over and over again as we talk about different injuries and body parts in our Module 1 training. We also have a much more elaborate M2 algorithm that I did not include in this presentation, but we cover that in great detail in our M2 training course. So practical integration, want to kind of move ahead, want to finish the webinar just introducing you to a case study, but GT is designed to help treat more subtle soft tissue lesions. It's simply another treatment option for your patients, especially if you already use soft tissue mobilization techniques, manual or other. The parameters for a typical GT treatment session, okay, we suggest no more than 2 times a week. And there needs to be, because there could be a pro-inflammatory effect, we suggest a 2 to 3 day period of time in between sessions. One of the earlier slides talked about the efficiency of the Graston technique. We mandate 8 to 10 minutes per session, no more than 30 to 60 seconds on a small local lesion, average 3 to 5 minutes per joint or muscle group. And our outcome studies have generally shown a positive treatment effect after between 4 and 12 sessions. And that's just looking at all the different diagnoses that the Graston technique might be effective for. Anticipated outcomes. Okay, what we are looking for is an improvement in range of motion, pain-free flexibility. We are looking for a decrease in pain, so improved functional activity, performance both at rest, during a test movement. Again, we cover these concepts much greater in our advanced training, which is our M2. You might find a decrease in the actual size of the soft tissue lesion, but we focus on an improvement in functional range of motion, flexibility, functional strength, performance of a functional activity, excuse me. Again, we talked early about the myth that GT needs to cause bruising or hurt, and we spend quite a bit of time in our trainings really disproving this myth that did come about much earlier, early 1990s. Initial research indicated that heavy pressure might be better, and we have since disproven this. So picture of this patient should never be your patient as you're using the Graston technique. So I want to spend the last couple of minutes just quickly going through a case study, one of my patients. And I have to say, this is probably one of the first patients that I treated with the Graston technique. And she really turned my head and opened up my eyes in terms of the benefits of the Graston technique. She had come to me, she's a physical therapist runner, 4-year history of hamstring tendinopathy and plantar fasciosis. She had had numerous other treatments. She had been to physical therapy and other clinics a number of times. She had cortisone injections, and basically one of the concepts that we promote in our trainings is the importance of treating the entire kinetic chain, and again, looking at her progression of dysfunction really opened up my eyes to the importance of including the entire kinetic chain, assessing it and treating it, and then incorporating GT with such things as movement, open to closed chain. So over the next couple slides, I'll illustrate that. So I think we would all agree that tendinitis is rarely treated. What we have found, longer-term changes in the tendon has promoted the term tendinosis. And you can't treat a tendinosis where there's chronic degeneration. You can't treat it the same way you would a a tendinitis. And oftentimes, if the tendinosis is superficial enough, you see a nodular palpation. This study here, published in 1999 in the Journal of Bone and Joint Surgery, indicated it really was one of the landmark studies, Nerschel, indicating that we really do have to treat tendinosis very different than tendinitis. And I would argue that the Graston technique allows you to do that. So what we try to do, if we have a patient, my patient that's the subject of this case study, I think would argue, given the 4 years that I was dealing more with a tendinopathy, tendinosis. So mechanical load introduced via GT to initiate a pro-inflammatory response, and then incorporate appropriate exercise to incorporate the cyclical loading of the tendon that has been promoted by some of the studies looking at the role of eccentrics in the proper treatment of tendinosis. So again, these are two principles that we combine very effectively in our M2 training course. And then appropriate stretching if it is in fact indicated. So my patient, 35-year-old former runner, hadn't been able to run for a number of years. She'd had a number of different treatments, including numerous cortisone injections. When I saw her for physical therapy, she was very frustrated, and honestly, I have to say I decided that her prognosis was very limited due to the longevity and severity of her symptoms and the fact that she had really participated in another number of other treatments. She had some key objective findings. So in addition to the fact that I found significant fibrosis with the GT instruments all along her posterior chain, hamstring, calf, plantar, she had some range of motion restrictions. She had poor motor control. Glutes were not necessarily firing. So to summarize, I actually saw her 10 visits, which to me, somebody that's had symptoms for 4 years, I don't think a 10-session treatment duration is that excessive. I applied static work to her posterior chain, which is what's being shown on this slide, visits 1 through 4. I then progressed to dynamic and weight-bearing activities, some of these techniques, so I'm using the instruments, but in a much more dynamic fashion. And then I progressed to weight-bearing. Again, I try very hard to replicate functional activity as part of my treatments. The plantar fascia fails under load, and so it's important with our patients, as soon as they can tolerate, that we progress to weight-bearing and loaded activities. Again, I can't emphasize enough the importance of active exercise, either during your GT session, which is shown here on the lower right, or at least after the soft tissue GT treatment has been completed. These are some of the exercises that I did with my patient, in addition to these. We encourage the use of complementary therapies. Many of our clinicians that are trained utilize kinesiology tape to facilitate the effects that are caused during their soft tissue treatments. And patient empowerment is important. Home exercise program. Patient has to participate in activities that complement what we're trying to do in our soft tissue treatments. So we also include a little bit of discussion in our Module 1 and 2 trainings about the importance of self-myofascial release, some of the theories behind why it may or may not be effective. And yes, home exercise is important, multimodal treatment approach, and I'm happy to say that we did have a positive outcome. Patient was back running 10 weeks after I started treatment. She began marathon training and was able to complete her first marathon. And I do keep in touch with her. She's one of my colleagues and has not had a significant reoccurrence of symptoms. And I did initially treat her in 2007. So again, this was one of my earliest and greatest successes with the Graston technique, and I included in this presentation just to show you how effective it can in fact be. So at this point, I know I went a minute or two over. I do want to thank you for sharing your time with me. I believe we're going to open it up to any questions that might have come in. And my email, if you'd like to email me directly, you can see my email address on this slide. And again, I want to conclude my part of the presentation by saying that in 30 years as a orthopedic manual physical therapist, the Graston technique has been one of the interventions that really has defined my clinical practice as a, I'd like to say, successful physical therapist working in the New England area. So again, thank you for your time, and I would encourage you to visit our website, grastontechnique.com, and feel free to shoot me an email. So thank you very much. Sam?
So we do have a question. Have you had massage therapists incorporate this into their practice?
Okay. Good question. I myself am a massage therapist. I went to massage school 2 or 3 years before I started using the Graston technique. So because I've always valued the use of hands over the soft tissues. Right now, we do not allow, we have a list of eligible clinicians, and because of the variability in the massage therapist training in this country, right now we do not allow massage therapists to participate in our trainings. We are investigating the possibility. In Canada, licensed massage therapists undergo a very rigorous course of study. They are considered healthcare professionals. So we do allow RMTs, registered massage therapists, to participate in our trainings and to, perform the Graston technique as part of their clinical practice in Canada. At this point, again, like I said, we are looking at the rules and regulations on a continual basis. But again, until we can assure some type of mandatory licensure, we continue to just investigate the possibility in this country.
Okay, and then also are PTAs allowed for the training?
Yes. Physical therapist assistants, as long as they work under the license of a physical therapist that is also trained in the Graston technique, they are encouraged. OTAs as well, as long as they work under the license of an occupational therapist that's trained in the Graston technique. And that's, honestly, to the PTs and OTs out there, that's for your protection. If you had a PTA that was trained in the Graston technique working with your patients and you were not trained in GT, that might not necessarily legally offer you the most protection for working with your patients.
All right, and then another question. Some of the contraindications seem to be medications.
Mm-hmm.
Does the Graston technique need to be avoided in acute conditions? Or does
Not avoided. I should have probably gone over this when the slide was up. A relative contraindication is a yellow light. It means proceed with caution. So what we encourage our clinicians, if you have a patient that's on an anticoagulant, it could even be aspirin. It's not that manual therapy is absolutely contraindicated, but you might need to consult with that patient's physician if they're an easy bruiser. At the very least, you would adjust your dosage parameters. And again, those are the types of things that we cover in great detail and why we require mandatory education in order for you to incorporate the Graston technique in your clinical practice. So the relative contraindications that were listed on the slides, I typically suggest having a discussion with both the patient and their physician before proceeding with treatment. In some cases, you will not use the Graston technique, but in other cases, you will proceed, but with great caution, documentation, and just make sure that you monitor patient response really carefully.
Any other questions from anyone? And if you think of something later, Jackie's email is still up
Yeah.
there. So
Yeah, I can't emphasize enough the importance of indications and contraindications. And again, that's why we do mandate that our Graston technique clinicians do complete our mandatory trainings. Those are really important things to consider. Thank you, Sam.
Thank you, Jackie. Looks like that's it for today. So
Okay.
thanks everyone for joining us. And again, thank you, Jackie, for a great presentation. And everyone have a great day. We'll see you next time.
Okay. Thank you very much. Hope that was helpful.